Good morning to everybody. Good morning. On a most spectacular day in Washington. After the last couple of weeks of snow, it's fantastic that we can enjoy the weather, and hopefully you'll have a healthful run around the mall when the session is finished. It's my pleasure as my name is Derek Yach. I'm the Executive Director of the Vitality Institute. For those who don't know, the Institute was recently established really to do two things, to try and galvanize the voice of prevention and health promotion, starting in the US, but we have visions of doing this globally, to make sure that prevention becomes the core of what healthcare should be about. And secondly, to work with many of you to make sure that we use the most evidence-based practices in driving better behavior change, and do that in ways in which we work closely with the public and private sector to lever their capabilities. One of the big launch events that we thought were important to do and before we start was to have a commission focused on the prevention of chronic diseases among working-age Americans. The rationale for that you all know well. While there's been stunning progress in health in the US over the last 5 decades, the quality of health and the health outcomes of the US population have been steadily slipping behind many of the OECD countries, and today are ranked lower than they were 2 decades ago compared to many countries at equal levels of development around the world. And the consequence of that is not just less health for individuals, but also translates into enormous impacts in terms of productivity and the economy of the nation, including the national debt. So it's with those weighty ideas that we felt it was important to have a commission that drew upon the best of the private sector, the public sector, NGO, and academia. And today's session focuses on some of the key issues that we're discussing, and a chance to get your views on how we can make this truly an impactful partnership process. Our wonderful host is Dean Lynn Goldman, who is Dean of the School of Public Health here at George Washington University, and known, I think, to everybody in this audience as one of our great leaders in public health, environmental health, and a wide range of related public policy issues. And it's my real pleasure to introduce her to take over the morning's proceedings. And a very warm welcome, and thank you to her for being our host. Lynn.
I, in turn, wish to thank Derek Yach for having invited us to co-host this forum today. I think that Derek has had a marvelous career in global health, and the prevention of chronic disease has been a major commitment, and he's been a force in this field. And yet, at this time, despite his efforts and the efforts of so many in this room and here in Washington, we are falling behind in the health status of people in our population. And I think we do find ourselves at a critical juncture in terms of facing both an opportunity to promote wellness in the population, and also numerous challenges and obstacles that have been placed in our path. And I'm delighted that this morning we're going to have the opportunity to explore some of those situations, hopefully to help to illuminate the work that the Vitality Institute Commission is carrying out in the area of health promotion. So, in the spirit of empowering change through policy, what I'm going to do is quickly move forward to introducing the chair of this session, and also the chair of the forum. Will Rosenzweig is an entrepreneur. He's a venture capitalist as well as an educator. Certainly an unusual entrant into the field of public health, but the kind of person that we need to work with if we're going to be successful in moving forward the wellness agenda. He was the founding CEO of the Republic of Tea, and he has been involved in growing and nurturing a number of food industry entities that have been focused on making food healthier. Odwalla, Stonyfield Farms, and Brand New Brands, a functional food incubator he founded in 2003. as well as chairing the Vitality Institute Commission. He, in 2010, was selected by a committee of Nobel laureates for the Oslo Business for Peace Award. This is an award that's presented jointly by the Business for Peace Foundation and the International Chamber of Commerce in Norway. He co-authored the best-selling book, The Republic of Tea, How an Idea Becomes a Business. It's wonderful to have you, Will, to moderate.
Thank you very much.
Thank you.
Thanks. I think I'll confirm all of your worst fears about somebody coming all the way from San Francisco to a meeting in Washington, D.C. This is the band that I took off my yoga mat in my hotel this morning. I realized how enticing this little cue was to get me to actually unroll that and use it, because I don't sleep that well, and particularly when I'm traveling, and so I thought, I'm going to have to get up and speak and introduce people, and so what I'm going to do. So I looked in the closet, and there was this little smiley face, banding around this yoga mat. And so the Kimpton Hotel is doing a pretty good job. They have 8 hotels here. Just a little plug for them. I think it was a little source of encouragement for me today, and hopefully it got my blood flowing. Hopefully I know this session today will. I really appreciate everyone coming out to see us. I guess the weather's keeping a number of people outside, but I know it's being telecast on screens outside. So today's session is really to focus on how the laws are impacting this realm of prevention. We've got really scholarly and notable thought leaders here with us today, so we're going to let people give you a little sense of what they're thinking about. In the design of the program, we're trying to bring together a number of different perspectives, and then we'll engage in a bit of conversation. And I would hope, like I do in my graduate school class, I always ask people to come sit in the front row. So maybe at the break, come a little closer so we can see you and engage you a little more actively in the conversation. The first session today is really to talk about workplace wellness programs and the context of how the Affordable Care Act is either helping, supporting, or hindering their evolution and their adoption. And our first speaker is Jennifer Pomerantz, and she's a assistant professor at Temple University and is a expert member of the Vitality Commission, very distinguished scholar in her field. And then Naomi Seiler is here from George Washington University, and she's going to join us for the second presentation. And then Lynn and Jeff Levy are going to begin a conversation with our speakers. So without further ado, let's welcome Jennifer Pomerantz.
Thank you. And thank you to GW and Vitality. I'm just looking at where the remover is. Oh, here it is. Okay. So today I will be speaking about workplace wellness programs. And so we are, here it is, okay. So we're all here for the same reason, to talk about how America is overburdened with chronic disease and we need to focus on prevention. The Affordable Care Act comprehensively amended the healthcare landscape. It also, for the first time, devoted some money towards prevention, but it also amended the law with respect to workplace wellness programs. The idea about a workplace wellness program is that it's a targeted setting to meet working age adults. At a minimum, we can get them to necessary health screenings, give them health education, but there's a really growing thought that an effective workplace wellness program could comprehensively address chronic disease problems and healthcare costs, which we know is a overburdening problem for employers, especially the healthcare costs in addition to lost productivity, absenteeism, and other problems. The evidence does show that investing in workplace wellness programs does address healthcare costs, absenteeism, and productivity. And so I'm going to talk about today how the Affordable Care Act did and did not actually reform the law in a way to make an effective workplace wellness program possible. So workplace wellness programs are defined as programs that prevent disease or promote health. There are two types. The first are participatory programs. These are either not associated with the attainment of a reward, or the attainment of a reward is associated with a non-health related standard. So something like a reimbursement for gym membership, or an incentive to attend a class, or to take a health risk assessment. Health contingent programs, on the other hand, are related to health outcome standards, and they can be activity-based or outcome-based. Activity-based health contingent programs are programs such as dieting programs or walking programs without having to show some kind of health outcome. The other type are outcome-based, which does require a health outcome, meaning you either have to maintain a healthy BMI, attain a healthy BMI, quit smoking. Those are health outcomes that these programs seek to target. Mostly large businesses have employee workplace wellness programs, and predominantly these are participatory programs. Unfortunately, small businesses don't have as many programs, yet they employ about half of the private workforce, and they, of course, have the same problems with lost productivity and healthcare costs as large businesses. One rationale is that they don't have the resources to quite create the workplace wellness program, and so there's ways to address this. So briefly, I'm going to just talk about participatory programs. There are no requirements on their use except for that they must be available to all similarly situated people. This can be in terms of employment status, such as all full-time employees, or health status, such as a disease management, let's say diabetes program. The most prominent type are health risk assessments, which means in this country the most common workplace wellness program are participatory health risk assessments, where an employee receives an incentive to complete a health risk assessment. Now, the department regulations define rewards as positive rewards and also the absence of a penalty. This actually conflicts with the EEOC, which is the Equal Employment Opportunity Commission's configuration of what they consider the ADA to prohibit. The ADA prohibits the requirement of health information. So there is a regulatory conflict here that I could talk about at the question and answer, but just more of a note that the equation of positive rewards and negative penalties could have some issues and also ethical concerns, whether if you're so highly incenting a workforce to have to engage in a program, where is there a line drawn for this? And especially on that note, the most used, these health risk assessments, there's not a good evidence base to say a health risk assessment alone without providing information to your employees is effective at all. So this is a lost opportunity there. But most importantly for my talk, there are no requirements related to efficacy, so it doesn't matter if a participatory program is effective at either increasing health outcomes or reducing healthcare costs. State bills and laws are being proposed and implemented to address some of the problems that I'm going to be discussing today. One in particular, Hawaii has a bill that makes the incentives have to be positive. So you could see that states are having some concerns with this voluntary nature of participatory programs. And these are issues that we're seeing states starting to take up. Now, health contingent programs, on the other hand, have 5 requirements. In order to not violate HIPAA, a health contingent program must abide by these 5 requirements. Now, you've probably heard a lot about the reward percentage, which is number 2, and number 5, the availability of a reasonable alternative. For the most part, that's what's making the news. But what's really been left out of the discussion and what was not changed during the Affordable Care Act is the fact that they must be reasonably designed to promote health or prevent disease. Now, in the legal terminology, the word reasonable denotes a low level of standard, but there's no definition except for what I'm going to show you now, which is quite unhelpful. A reasonable opportunity must mean it has a reasonable chance of improving health or preventing disease. It's not overly burdensome, not discriminatory or based on a health condition, and not highly suspect. Now, to use the term reasonable to define the word reasonable is a problem, especially for lawyers when we're looking for an actual definition. So that is a low standard, and there's a concern about whether it matters if this is effective. If it's just reasonable, it might not be. And in fact, there are no requirements for workplace wellness programs to use an evidence-based standard. The department suggests that employers look at evidence-based standards, but there's no requirement that they do. Why? Flexibility. They want to give employers flexibility to come up with their own plans. Another reason, innovation. Let's let employers innovate. This is great, but the problem is that there's no incentive for a real investment in evidence-based programs. The other problem is that the department's 2006 regulations, which are still law, they refer to aromatherapy as a possible program that would meet this reasonable design requirement. Now, aromatherapy might be fantastic when you're getting a massage, but in terms of actually improving health or preventing disease, we could probably all agree this is not the solution. So we're really talking about a lack of an evidence requirement, which really undermines the potential for an effective workplace wellness program. And in fact, when the departments are trying to encourage health contingent programs by making this loose standards, it's not working because they're not widely used. Still, participatory programs are the most common programs. And we do see that I would argue we need to move beyond this idea of wellness to really talk about health promotion and disease prevention. We need to support evidence-based programs and the research into evidence-based programs. And the goal would be to have efficacy from both a health standpoint and financial benefit to the companies investing in them. Now, my suggestion is that instead of suggesting the employers use the guide to community preventive services that are based on the Community Preventive Service Task Force recommendations, we actually move towards a system of requiring it. Now, the Community Preventive Service Task Force is an independent panel. They are created by HHS, and they are administered and funded by the CDC. They evaluate studies, they look at costs, they look at cost effectiveness, and they make recommendations on community prevention, including workplace wellness programs. So my goal would be that we give some time to innovate. This would build an evidence base, and then we eventually require the implementation of an evidence-based program. And we would couple this with a grandfathering provision so we can minimize opposition and disruption to programs that are already in place. This evidence base would also help small employers who do not have the resources to develop their own programs. And the way I see this happening is to use a precedent from the Affordable Care Act that requires insurance companies to use one of the recommended services by the United States Preventive Service Task Force. So in my mind, what we should do is create a similar compilation of effective workplace wellness programs, among which the employers and their program operators can choose, and these are the ones that they should be using. So also we have seen state laws and bills that are dealing with this issue. California has a defunct bill that actually would have done away with health contingent programs, the same idea of trying to keep voluntary incentives. But fascinating, they did have a section in it that required employers to actually have their employee wellness programs approved by the California Department to make sure that it's actually reasonably effective from a financial and health standpoint. So this is a real need and an innovation. California is thinking about this as well. Also, for any kind of workplace wellness program that is incorporated into an ERISA group plan, ERISA provides a private right of action to beneficiaries of these plans, which means that a beneficiary or participant actually may sue the program operator. And we haven't seen any of this yet, but there is a chance that if an employer implements some kind of crazy program like an aromatherapy requirement, there is a question whether is this bizarre, is this really a reasonable design, is this using to promote health? I think reasonable minds could differ, and that means a jury would be questioning whether your program is really reasonably effective. And I can imagine no employer wants to leave this question to a jury. Rather, they should be using best practices. And just a final note that the use of best practices does not automatically mean that a program is implemented effectively or participation is exactly as they are expecting. So program evaluation is, of course, in an employer's best interest. This is not required in the law, but program evaluation is a missing component for them as well. So I thank you, and I look forward to your questions.
Is my presentation? Excuse me. Thank you so much. Hi, I'm Naomi Seiler. I'm here at George Washington University. I'm not actually going to be speaking about workplace wellness programs. I'm going to be speaking about another policy change effected through the Affordable Care Act with an enormous potential influence on preventing disease and promoting health, including chronic disease, and that's coverage of preventive health services primarily in a clinical setting. I'm going to talk about what these services are that are covered by the law, and then give you a feeling for how the requirements under the Affordable Care Act are being operationalized in very different ways across different types of payers, and then end with a set of questions that I think that complexity and variation raises. So Section 2713 of the Affordable Care Act includes a number of types of clinical preventive services. The first are services that get an A or B grade from the U.S. Preventive Services Task Force. So that is the complementary task force to the Community Task Force, which Jennifer was describing. The Preventive Services Task Force similarly is an independent panel of experts which in the past established these grades for preventive services for clinical providers, but now, as we'll see, it takes on a larger role within coverage issues. Immunizations that are recommended by ACIP, which is the Advisory Committee on Immunization Practices. Certain preventive services for children that are recommended by HRSA, and certain recommended services for women recommended by HRSA. So just to give you a sense of how broad this list is, and I'm sorry, these are going to be hard to read, but I wanted to make clear that for both chronic conditions, infectious diseases, lots of different health areas, these are really important interventions. You can see, I hope, cholesterol screening, depression screening, diabetes, lots of chronic issues here, lots of potential for preventive services to help people both get, and this is a mix. There's screening, there's counseling, there's intervention. It's a fairly flexible definition of what prevention means here. These are the services for all adults. These are the services specific to women, which, as you may know, includes contraception, which there's been some debate about. I won't get into that in this talk. And these are the services for children. So lots and lots of preventive services which certain people, and we'll get into detail in a moment, are going to have increased access to under the Affordable Care Act. So the idea is increased access without cost sharing. Cost sharing is, a barrier to medical care in general. It can be, in particular, a barrier to preventive services because, in general, people aren't suffering or feeling the effects of something when they get preventive services, and so cost can be more of a barrier to people getting those screenings, that counseling, et cetera. But the way coverage works is going to vary significantly by type of insurance. First of all, whether the requirement exists at all, and second of all, how it plays out and how you can actually access these services. So I'm going to start with private insurers. The most important thing, I think, is that this applies, the requirement to cover Section 2713 preventive services without cost sharing applies in exchanges, which, as you may know, are the way that people are going to access insurance at the state level, newly insured, and outside of the exchanges. So anyone with private coverage that isn't already that isn't grandfathered. And at this point, I believe a majority of plans are not grandfathered. So again, in these plans, people are supposed to get access to all of those preventive services without cost sharing, but that's easier said than done. You can look at the task force, the U.S. Preventive Services Task Force. You can look at the immunization list and say, great, I get these services. Well, that doesn't translate the service into how does coverage work. So there are a number of complexities. The first one is the doctor billing for the service or the visit. And as this sort of detailed list outlines, if they're billed separately, the doctor can still bill you for the visit. So someone might say, oh, I want to get this preventive service. I'm going to go to my doctor and get screening for hepatitis. I'm in a high-risk group. Well, if you go to a provider who bills the visit separately, you might not get billed for the preventive service, but you can get billed for the visit. If the service isn't billed separately and you primarily went for that preventive services, then you're okay. If they're not billed separately, but you went to the doctor for a different purpose, let's say you weren't feeling well, you went in for a strep test, and while you were there, you said, hey, I think I'm high risk for hepatitis, can I access this screening? You can be billed for the visit because the primary purpose of the visit was not the preventive service. Finally, if you get any of these services, these preventive services, and let's say it's a screening and it detects some sort of problem, any of your follow-up you can be billed for. Next issue, network versus out-of-network providers. Many of us these days in private insurance have plans that rely on some sort of network. If a plan does have a network, they're not required to cover preventive services out of network. And if they do decide to cover them out of network, they can apply cost sharing. So again, you may go in thinking, well, I get these preventive services, but if it's not a network provider, you may have co-payment, co-insurance, or have to pay part of your deductible. The exception is if there is no in-network provider who can do a certain preventive service, you can go to an out-of-network provider and the plan has to cover it without cost sharing. Now, again, that's great, but when we're thinking about how do we increase uptake, how do we translate all of this into practice, how many people are going to know or understand that? Probably a very small proportion. Frequency, method, treatment, or setting. So this goes back to the fact that the U.S. Preventive Services Task Force really was created to establish clinical standards for providers and not to establish clear insurance coverage rules, right? So what the law says and what the regulations say, the interim final rules, are that if the task force has said how frequently something can be covered or in what kind of setting it can be covered, plans have to follow that. But if the task force is silent on any of those issues, and often they are, then the plan can apply what's called established techniques and the relevant evidence base, which again are pretty general terms, to establish limitations here. Switching to Medicare. The Affordable Care Act does not require Medicare to cover Section 2713 preventive services. You hear people out there saying, oh, now Medicare has to cover all these preventive services. There's been no change in whether Medicare has to cover them. Medicare can cover Section 2713 services, specifically the USPSTF and the ACIP services, the immunizations, but they don't have to. The change that the Affordable Care Act made is that if Medicare covers such services, they have to do so without cost sharing. So that is a benefit to Medicare beneficiaries. However, Medicare does not have to comply with what the task force says about setting or type of provider or frequency. So one issue that my colleagues and I have seen looking at this is that there are a few different services where the task force has said, well, this could be provided in A, B, and C settings. But Medicare, fairly consistently across a number of determinations now, has said, okay, we're going to cover this preventive service, but we're only going to cover it when it's provided by a primary care provider in a primary care setting. So drawing lines that are narrower than the underlying recommendation. And this is a concern, to give you an example, STI counseling for sexually transmitted infections. Essentially, under Medicare's coverage determination for this, even though the task force says this can be done in an STD clinic, which is logical, by an STD, an infectious disease specialist, Medicare says they'll only reimburse if it's done by a primary care provider in a primary care setting. So this narrower interpretation may lead to narrower access. Finally, Medicaid. In traditional Medicaid, and in this sense I mean pre-expansion, folks who were already eligible before Affordable Care Act expansion in some states, there's incentive for states to cover the whole list of Section 2713 services, not the HRSA ones, but the task force and the immunizations. So that's great. They get a 1% boost in their federal match. So far, from our understanding, and not all the information is public yet, it looks like only a handful of states are actually doing this. And it's quite difficult, frankly, to understand what states are covering. If you look at, there's some recent research by my colleague Sarah Walensky in the department saying, some states say, oh, we do cover, this test. But really, it turns out they only cover it when they deem it medically necessary, as opposed to covering it as routine screening, which is what the task force may recommend, right? So there's a lack of clarity as a baseline, and now, some states might be covering more of these, but again, we're not sure which states, and again, how do you translate that to people and providers who you actually want to take up these services? States do have a new option of reimbursing a broader set of providers to give these services, and that's an opportunity I'm happy to talk more about. Folks who are newly eligible for Medicaid in states that are doing the expansion do have to have access to all these services, and after some uncertainty in the rules, it looks like that will be without cost sharing, so that's a good thing. So where does this leave us? It leaves us with a lot of questions. As far as awareness, and the basic principle being, you have law, you want uptake, how do you make that occur? How do we communicate all of those confusing things I just explained to patients? How do we communicate them to providers? Those are the two main audiences, although not the only ones, who you want to know about this increased opportunity, but how are you going to get that information across to them in a way that conveys the nuances? From a policy perspective, so if you assume that Congress isn't making any legislative changes to the Affordable Care Act anytime soon, one issue is the Medicaid coverage, right? Coverage of preventive services. Most of that now is going to be a state issue. How do you convince states to cover all of these services? Is the 1% FMAP boost enough? From a Medicare perspective, is there a way to broaden the settings, the types of providers that Medicare will cover? From an enforcement perspective, this is something that some of my colleagues and I are very concerned about under the Affordable Care Act in general. Most enforcement of private coverage under the Affordable Care Act is going to be at the state level under state insurance commissioners. And that is a lot of new policy, a lot of new areas of health for them to be enforcing. And so with regard to preventive services, as well as to many other types of health care, is that level of enforcement going to suffice? If HHS does step in, which they can in certain circumstances, is that going to suffice? Are they really going to be able to do that at a level granular enough to make sure people are able to access these services? Finally, from a research perspective, I think there are a lot of really exciting and interesting both kind of policy and quantitative research questions that come out of this. First of all, how are issuers, plans themselves, interpreting the law and guidance? What are people actually experiencing? Are providers getting appropriate reimbursement? And this goes into the next bullet, which is, a lot of providers get bundled payments. They might get a per encounter payment. So how does that work? Are they getting sufficiently reimbursed to provide all the preventive services that may be appropriate? And then finally, and I think these are the most important questions, is this coverage actually increasing uptake of preventive services, and is increased uptake improving health? Thank you.
Well, Naomi, I think you've asked all the questions. But I saw Jeff really scribbling away there. It was making me really nervous, like there's going to be a test or something. This is quite a way to wake up in the morning, isn't it, to two lawyers? It's really intense.
And it's really early for you.
So, Lynn and Jeff, do you want to start the conversation?
Okay. So I think just a brief comment and then some questions or a question. And I think the comment is that these two presentations demonstrated a theme that's part of the Affordable Care Act that we sometimes don't always acknowledge, which is the Affordable Care Act, even though all of the attention has been around insurance coverage, is really taking a more holistic view about how we create health or wellness, and really thinking about what happens both inside the doctor's office and outside the doctor's office in being able to bring about a healthier population. And so, a lot of my work is focused on what happens outside the doctor's office, but I think it's important to say first and foremost that even for those of us who care about what happens outside the doctor's office, coverage matters. In particular, for those of us who are concerned about disparities, the Medicaid expansion matters, and we have a rather horrible and probably unethical natural experiment going on about what that means, about whether you have Medicaid expansion or not. And I think just as importantly, the financial incentives that are driven by some of the Affordable Care Act changes are in terms of the healthcare delivery system is really pushing that system to also think about what happens outside the doctor's office and think about population health. And then there are very specific things that are part of the Affordable Care Act, the Prevention Public Health Fund. But I'm assuming the Acting Surgeon General will also talk a little bit about the National Prevention Council and the National Prevention Strategy, which is bringing 20 federal agencies and offices together to recognize that it is not just health agencies that have an impact on health and on wellness, but everything from transportation to education to housing to urban development and so on. That said, I think how we manage these expansions, whether it's around clinical preventive services or the opportunity around workplace wellness, is really challenging. And I think Naomi did a really wonderful job of posing all of those difficult questions. And I think what ran through both of these presentations, and I guess I'd like to ask you for your potential solutions, is how we translate what are, even when it's evidence-based recommendations, into practice in a meaningful way. So the U.S. Preventive Services Task Force, for example, was never set up to determine insurance benefits. And to ask them to do that, I think, is a real challenge. And the public health world has had issues with USPSTF because they've been very slow sometimes in adopting what the public health world feels is adequate evidence. And your hepatitis example is a perfect one. HIV screening took them 10 years to catch up with CDC recommendations. But how, in the case of the clinical services, what is the solution to translating those guidelines from a clinical recommendation into insurance speak? And I think similarly on the workplace wellness side, even if we had a requirement that you have to follow a program that got the seal of approval from the Community Preventive Services Task Force, how do employers make that transition? Because they're really talking at a 30,000-foot level and doesn't necessarily tell the average employer how to translate that into practice. And so how do we bridge those gaps on both the clinical and the non-clinical sides? Because I think it would be useful, as a commissioner, I think, as we're looking at these issues, it would be useful to have a practical solution to this translation problem.
I mean, I think there are two ways. On the clinical side, I think there are a few different ways you could go about it. If your assumption is that having a standard translation is a good thing, that's not necessarily true. People who want broad access might be disappointed if some sort of standardized translation of the recommendations into coverage were less generous than one hoped. You might then prefer to go back to more flexibility and hope that you can persuade some issuers, some payers, to cover things more flexibly. But if you assume that there would be some use to some sort of central definition of how each preventive service, and I'm just talking about preventive services here, not coverage more broadly, to how each could be translated into coverage, there's a few different variables you'd have to think about. I mean, first of all, should there be a separate entity from the U.S. Preventive Services Task Force? Let that task force focus on clinical and giving recommendations to clinical providers and kind of wall themselves off from thoughts of coverage, which for now I would imagine must be very difficult for them given the scrutiny they're getting, and have a separate entity. Then the question would be, well, how separate, how independent? Would it be a federal advisory committee and have all the transparency and requirements of that? And secondly, would their recommendations be mandatory or not? I think would be a big thing. They could just put out recommendations for translating the services into coverage, and a lot of payers might be grateful for that and take them up. Or it could be mandatory, which would require legislative change, which I think, for many reasons, would be more of a barrier right now. But I think just personally, I think there's something to the idea of separating that from the role of the task force.
So similarly, I would think that the Community Preventive Service Task Force can take a role in interpreting the requirements. They do right now have recommendations that are more than just a sentence of what the recommendation is. They've evaluated a lot of evidence. They could go further. And then the other side would actually be to let the marketplace, which is something I never usually talk about as a public health person, but honestly, that employers can look towards independent providers of workplace wellness programs that would have to figure out a way to translate the recommendations into an effective program that not only helps health but also is financially effective. This could be coupled with an accreditation system where, then employers can look towards these independent providers to institute their wellness programs. And I think that could actually be great, and also keeps them out of the ERISA group plan if it's not part of the health plan, which would avoid that ERISA litigation issue.
So just one quick follow-up. You're willing to let the marketplace decide what is effective translation. Why not let the marketplace decide even what's an effective workplace wellness program? Because why would an employer invest in... The employer is doing this to have a more productive workforce and lower healthcare costs. Why would they invest in a program, or continue to invest if it failed, in a program that didn't achieve those goals? Why do we need the government coming in and telling big businesses how to develop their workplace wellness program?
This is a Socratic Methods law school class. I'll tell you why. Because employers are so excited to be like, we offer gym memberships to our employees. Wow, we are so great. We reimburse gym memberships. So, for employees, go to the gym. Did that really make a contribution to anything except for that now they have something to talk about how great they are? And I would also argue that we don't want the marketplace to take care of what's effective. That would be the Community Preventive Service Task Force to have the list of recommendations, whereas the independent providers could be the ones to translate it for the individual workplace to make sure it's effective at that workplace.
Lynn.
Yeah, so like Jeff, I'm quite impressed with it's a sea change in terms of the way that we're now beginning to view evidence as a basis for what we're doing for prevention in the clinic or what we're doing in the community, and that's a really, really good thing. And at the same time, I'm very aware that the processes for evaluating that evidence are very rigorous, and it is not easy to generate evidence that meets the standards of these task forces, which is a good thing. I mean, you want to have those recommendations based on very strong evidence. And as you pointed out, Jennifer, I mean, there are many experiments going on out there in workplaces that are not being evaluated. And even if they're being evaluated, they're probably not being evaluated in a way that will result in evidence that can even be reviewed by the task force. And having been involved in many of those processes myself, I can appreciate that. There are many things that you wind up having to give very low weight to those because they're not really rigorously conducted. And we can't exactly do randomized controlled trials for many of these preventive measures. Pretty hard to match companies or match communities. So we need to be able to support, I think, the efforts that are out there to begin to generate that evidence, which to me says building partnerships, between academics, between industry, foundations, others who are engaged in this, to be able to have the assessments be independent assessments and credible assessments that are actually published, but also to support being able to, if you may, build a more rigorous foundation of research in prevention, in clinical prevention and in community-based prevention. And it's my bias maybe, but this has not been a strong focus of the NIH. I think that there's been far more emphasis on translation of research to the bedside for cure of disease than for promotion of prevention and wellness. The CDC is very focused on this, but they don't have funding for research. There's very little funding. When you look at HRSA, ARC, and I'm pretty sure that my researchers at George Washington are as good at searching out all of the potential sources as anybody to be able to move into this space, and it's an extremely small space. And so I guess the question that I would have is, how that space should be created, who should be involved in enlarging that space, and your thoughts on that as young researchers who are trying to make a mark in this field. What you would like to see.
Well, I think one thing that we're seeing that, and I'm not saying this is good or bad, is that disease groups or health, groups that focus on a particular area of health are the ones who are most invested in the preventive measures related to their disease, right, or the area of health or the particular disparity that they're concerned about. And so I do think some of the impetus, if not the funding, is going to be coming from sort of the outside, the advocacy world. And that's not necessarily a bad thing. It does raise a question of whether there are issues or diseases for whom there is less of a voice or less funding, and will those inevitably be underrepresented in the research and ultimately in the recommendations. So that's, again, I don't have a concern about the groups that exist promoting research and robust guidelines related to their disease, but I do have some concern about other things being neglected.
Yeah.
Well, since the departments for the workplace wellness programs did say that they would be open to amending the regulations, and I believe that they could amend the regulations to eventually have a requirement, if such a requirement did exist, then employers would be incented to start investing in evidence-based programs. And I think also funding research maybe through academia to evaluate these programs, or we all know Kaiser is constantly involved in this, and there are groups that could evaluate the research, but it would really need the impetus of a requirement for evidence-based research, I think, to get that started.
And if I could just make a quick plug for other work that the Commission has done, because it follows up with what Lynn said, which is a really comprehensive analysis of how NIH research dollars are being spent, and surprises, I don't think I'm giving away big secrets here, that very little is on the kind of prevention we've been talking about. And that's going to be a huge gap that's going to make it very hard to impose requirements to follow an evidence base when the research hasn't been really done in a robust enough way to impose that mandate. And I think that's the big challenge that we face.
We're running a little bit behind schedule, but does anyone have a pressing question while we have our legal scholars on the stage? Somebody?
There's a mic in the...
There's a mic in the center, if you'd like to. And Jillian, Ron Getzel has a question. Ron, could you introduce yourself and just let everybody know
Sure.
your
Ron
relationship
Getzel,
to the Commission? Yeah.
Emory University and Truven Health Analytics. I also sit on the Community Guide to Preventive Services. So there are a few realities and practical issues related, Jennifer, to your recommendations. Number one, it's been talked about is funding. So the Community Guide budget has been zeroed out as of the last compromise agreement in Congress. So there is no funding for the Community Guide. Research...
yeah, you had corrected me on this too.
Yeah.
There may be.
Well, it's up to Dr. Frieden to make that decision. The congressional appropriators believe that the money for the Community Guide, the Community Task Force, is in the base, and given that CDC has gotten over a $500 million increase over fiscal 13, it shouldn't be hard to find that money in the base.
I was nervous about that too. And
It's a risk.
Well, all right, so that'll be negotiated at some point, but the work right now that you allude to is in jeopardy. Also, the funding for research, applied research in workplace programs, is minimal because federal agencies don't fund that kind of research. As we've mentioned, it goes to NIH laboratory type of research primarily. When you talk about proving or documenting that these programs are financially and clinically effective, what do you mean by that?
Well, it would be, I guess, for the employer to find that they have financial savings. Some programs are found to be cost effective in terms of like smoking cessation has positive health outcomes. But in terms of and then they could evaluate whether I would have to say whether the employers are undertaking the workplace wellness program, but like the Becker study did show that there was health benefits and increased productivity and decreased absenteeism. That's not my field. I don't have the biostatistics to tell you how they came up with that, but that would be for an evaluation.
Right. So that review done by Baker, Cutler, and Song was done on very large company programs. What about an employer with 10 employees? How would that employer document clinical and financial outcomes?
I have to tell you, I'm a lawyer. I don't have the expertise to answer that type of question, but I want to emphasize that I think employers should be paying for their own evidence-based research for their own practice, for their own employees. They should be investing in it in order to try to come up with a financial gain. I think employers probably think the health benefits are only care about the health benefits if it does have some kind of financial gain for them. So they should be investing in it. And my goal would be, obviously, if the departments did alter the law, it would encourage employers to have to invest in evidence-based programs. I don't see outside funding doing this. I see employers investing in it.
Well, just one final point on that. Large employers are able to do that, but even they, minimal number, invest in good large-scale studies. Small employers would never do it because it's practically it's impractical for them to do that.
Building the evidence base, and then I would hope that the Community Preventive Service Task Force could evaluate the large employer. Look, who would scale it down for a small employer is, again,
Lynn.
So I think you're pointing to a very important issue, which is not only that many employers will not have the capacity to do that kind of research and evaluation, and that there needs to be some creative thinking about how to work with the vast community of employers who really employs more than half of the population, and provide them with sound information about what they could be doing. And I think there's possibly a role for public health, people who are engaged in public health at the local level, who are in communities, who work closely with those employers. But also, one thing I'm very aware of is that even if you can prove a positive return on investment from these activities, employers are interested in, well, how long is it going to take to achieve that? If you're telling them in 10, 15, 20 years they will see ROI, they're not likely to take that as a sole incentive for being able to make these changes. And so how to provide incentives for people to take actions that have a massive return on investment, but over a longer time period. You can't expect that people alone are going to make those investments. A small business owner is going to make that investment. There need to be other incentives that can be created.
Lynn, the last forum that the Vitality Commission held was in Denver with the Denver Chamber of Commerce, which is one of the leading sort of proponents of health. And the key message that came through was that it was all about culture, especially at the small business level. And so it was very difficult for people to deconstruct sort of the healthcare portion of this from the loyalty, productivity, recruiting appeal, spirit, this sort
feels good to have a health club membership. Feels good, right?
It feels good to work here,
right.
And it feels good to perform and succeed.
Right.
And that's not an unimportant measure for an employer.
It's not an unimportant measure. And I think the key word I sort of heard coming out of this discussion was translation. And it seems like the complexity of these laws, especially for a novice lay person like myself, is extraordinary. The next panel of experts that we're going to have here is going to talk very much about translation, is how do we translate ideas, how do we translate laws, how do we create messages that are going to engage and amplify the prevention message. So before we have a break, though, we have a special guest named Andrea. Where are you, Andrea? Are you here? Where are you? Somebody's going to go find, might have to have Andrea come back. Let's do this.
Wait.
Is she here? Is she hiding behind?
And come forward.
Come on out. Great. Andrea's from Playworks. Playworks is a really incredible nonprofit organization that operates in 26 cities.
23 right now.
23 cities. And specialize in getting people up off their and out of their chairs. And we just thought, since we're the Vitality Commission, that we've got to participate with this too. So I'm turning it over to Andrea for a few minutes, and then we're going to go have a short break upstairs with some tea and fruit, and then back here for our next session.
You're welcome to stay and play. Evidence-based workplace wellness program. Okay. And the reason I say that,
I think we did.
you may, good, I'm glad you did. And I say that not only because in our own, can you hear me without the mic? No, okay. Is this on? Okay, great. The reason I say that is not only because at Playworks, we take play seriously in our own workplace. We have a 4-square court marked out at our office, and we do recess. We take walks when we need it. All of those sorts of things. We get a little bit for membership for some sort of wellness. But the real reason is that kids' workplace is school, and that's where we operate. And so, because we're in school, we take play seriously, and that really is a wellness program for kids in school. And I was especially happy to hear the things you were saying at the very end that are the least quantifiable pieces about being happy where you go to work, about feeling good to be there, about feeling respected. Because if kids are not happy and don't want to go to school, they're not going to succeed in school. But also, we're evidence-based. And I'll talk a little bit about that first. But because we're Playworks, we like to play. We're going to do a really quick game, 2 really quick games. The first one is called Stand Up. And so I'm just going to ask you, the way this works is just I'm going to ask a few questions. You can sit down to start if you want. If the answer to the question is true for you, ask you just to stand up where you are, or if standing up isn't what you feel like doing today, you can just lift your arms. Then just take a second to look around and see who else is standing, and then sit down again. So the first question is, if you are a parent, stand up. Okay. If you have been staying up too late watching the Olympics, stand up. If figure skating is your favorite thing to watch at the Olympics, stand up. And if figure skating, I'm from Maine, I'm with curling. If figure skating is your least favorite thing in the Olympics, stand up. All right, okay. If your kids come home and talk to you about recess, stand up. Okay, interesting. Okay, here's the last one. If you knew that pink is not just a color, but a campaign of Victoria's Secret, stand up. Oh, I am impressed. I just learned that this week. Okay. Okay, we are going to do just one more quick thing to get you moving. One of the things that Playworks does is we teach kids on the playground to use rock, paper, scissors as a conflict resolution tool. How many of you know how to play rock, paper, scissors? All right. It works amazingly well for things like I was first in line. No, I was first in line. Or the ball is in or the ball is out. Or when we play switch, which is a variation of musical chairs, that we both land in the chair at the same time. And so instead of fighting about it, quick game of rock, paper, scissors. It's settled. You get on with the game. More time to play. So this game is called Rock, Paper, Scissors, Rockstar. And the way it goes is that you find somebody near you, and you play a quick game of rock, paper, scissors. And the way we do that, I have to put my mic down for a second. So you find somebody, you play rock, paper, scissors with them, one game, 1, 2, 3, shoot. Whoever wins, whoever is more successful, the one who is least successful gets behind and starts cheering for that person, right? And the winner, the one who's more successful, finds somebody else who just won that first round, and you play a round of rock, paper, scissors with that person. The person who's least successful gets behind. So what's going to begin to happen is that you're always finding somebody else who won, and the other people get behind and start cheering for the person who's winning. And we're going to keep going around and around. We should end up with 2 people in this whole room playing against each other and everybody else cheering wildly. You'll be up out of your seats and ready to go get refreshments or go to the bathroom, whatever you need to do. Okay? So, find somebody near you. Ready? Okay. And go. Play. 1, 2, 3. Okay. Okay, just one round. Okay, just once, and then whoever won, who is more successful. Okay, so you find somebody else who won. Find somebody else. You get behind, and you're cheering for him. You're now his cheering squad. Okay. Okay. Shoot. Okay, so now. So you get behind, you're cheering for him. Okay, everybody should be playing or cheering. Okay, who won?
Okay, we're all behind. We have a winner here.
Okay, so 2 people play, and you're cheering for her. Whoever lost, whoever was least. So Howard, you should be cheering her on. Who won?
How do you like that? All right. Let's take a quick break and come back at 25 after 10. We've got really an amazing group of experts up here on the stage. We're really honored to have them. This second conversation today is really going to talk about how we bring the message of prevention to a broad variety of constituents. And each of the people on the stage really has a lot of experience. I mean, one of the questions that came out of the last panel for me with all the complexity around the laws, where does the responsibility for the uptake of health and prevention begin? Where is it encouraged? Who owns it? Where is it owned? And how are the messages to lawmakers, to physicians, to public health officials, to individuals, to employers, how are those messages, how do they need to be constructed to be effective? How do they need to be nuanced or adopted? I mean, these are some things I think we're all really interested in. We've tried to bring people with expertise from a variety of perspectives here today. Let me introduce you to our speakers. On my far right, Dr. Stephen Cha. He's the Chief Medical Officer of CMS, and he provides clinical input and guidance for the health coverage for nearly 60 million people who are served by Medicare and Medicaid. It's extraordinary. So that's quite a population. We're really honored today to have Rear Admiral Boris Lushniak here with us, the Acting Surgeon General of the United States, and has a very, very distinguished career in public service and with the FDA. And I had the pleasure of meeting Dr. Lushniak last night, and he's an incredibly passionate and knowledgeable and effective leader and communicator. Dora Hughes is here. Dora has worked in the Department of Health and Human Services. She's a doctor and has got a Master's of Public Health, worked on many really interesting agenda items with the White House around obesity and tobacco, and is now a senior policy advisor at Sidley and Austin. And then finally, right here to my right, Drew Lieberman is a vice president at Greenberg Quinlan Rosner Research, and really has a lot of expertise on how prevention and health promotion messages actually reach individuals, citizens, consumers, right? So what I'd like to do is ask each member of our panel to speak briefly about your perspective, the constituents you're trying to reach, illuminate us a little bit with your insights, and then we'll join together in a little bit more of an active conversation. So, Stephen, please.
Sure. Thanks so much for having me. I really appreciate the chance to talk with you all and be part of this conversation with this fantastic panel. Just one quick correction. I'm the Chief Medical Officer for just the Medicaid side of the House, just the 60 million of us in Medicaid. If you want the 50 million in Medicare, you need to go get Patrick. And But I think we spend a lot of time with our state partners. We are a joint state federal program. Altogether, we do serve 60 million Americans, nearly half of births in this country, one of the largest providers of behavioral health services for people in this country. We are a big piece of the pie in terms of thinking about the intersection between what people call public health and health delivery systems. I think that when we think about what prevention and population health and some of these themes mean to us, I think you got to take a step back, at least for us, and talk about our larger mission. And I think those of you who've heard from CMS and HHS anytime in the last few years have probably heard us talking about our general intent, which is under the ACA, we want to create not just a system that covers everyone, but a system that can actually address the needs for all of our populations. This idea of better health, better care at lower costs. And I think that's what we are committed to in terms of trying to think about how can we implement this vision across the board. When we think about better care, I think it's really critical that we recognize that the concept has always been about the health of our population. It's always been how do we actually serve and improve the health of the population whatever way we can. And so when we think about population health, it's more about this is one tool in our toolbox in terms of thinking about how we can tackle this together. I think where we've been shifting the conversation as well is this idea of linking outcomes and paying for outcomes rather than paying for widgets. And so I think that the discussion this morning, for instance, I thought was incredibly fascinating. I think we have a lot of activity on both of those fronts. I think you heard a little bit about certainly the benefit coverage and some of what we're trying to do with it. Naomi did a fantastic job of summarizing what's an incredibly complicated and confusing topic sometimes, and I thought she hit the nails on the head in terms of here's where the picture is as per the ACA. And we're working with our state partners to get uptake on that. I think we have somewhere around 8 states. I think that was the question. And I think we have more to come, and I think states are just trying to figure out how to bring those into the sphere of their work right now. The workplace wellness, I think we don't have workplace programs, but we have a lot of states who are thinking about how do we think about bringing the beneficiary into the picture. As we think about transforming our delivery systems, as we think about transforming our payment systems, how does the beneficiary fit into this picture? And I think we've engaged with our state partners around that aspect as well. A lot of the same questions that I think were described this morning, we're struggling with our state partners as well on that sort of population-wide level about what does this look like for a Medicaid population, particularly given the fact that you're talking about a low-income population. There's very little data, very limited data about what financial incentive means to someone at 50% of FPL, right? And so I think we are more cautious, but I think at the same time, within this broader context of saying how do we really transform our delivery and payment systems, can this be a piece of this? So I think where we're trying to direct is this can't be your sole piece, but rather, if you're really trying to turn all the dials in your system and really trying to think about the population health as a whole, can the beneficiary be part of that story as well? And I think we've been engaged in that conversation with some of our state partners. But on the population health side, I think it really is trying to think about not only, I guess, to think about 2 angles and 2 vectors here. One is moving our payment systems. So I think we're trying to think about can we assign more incentives and more of our federal investments for the kinds of outcomes that we want to achieve, and particularly in the field of public health and population health. So not just can we hold that provider accountable for rehospitalizations, but how do we think about statewide rates of rehospitalizations? Can we think about ways to hold the state accountable for some of those funds? Statewide rates of immunization. Even we've begun talking about obesity rates and infant mortality rates, but I think the idea that's a little bit more of a struggle in terms of where the levers are and the time frames for some of these incentive programs. But we're having those conversations, and I think in partnership with our CMI partners as well, and really trying to think about the fundamental theme. And then I think there's the delivery reform piece, which is how do you actually change the way care is delivered so that you can meet those incentives. So whether it's the health homes, whether it's the idea of hotspotters and superutilizers, whether it's early elective deliveries and interventions there, it's the specific how does care change on a ground level that can help you be successful in meeting those incentive changes. But I think the fundamental theme behind all this, and then I'll pause and let some of my esteemed colleagues jump in here, but the fundamental theme for all of this is really trying to think about how do we link our systems and create a seamless set of benefits for our beneficiaries, rather than saying this is what CDC is doing, this is what OASH is doing, this is what SAMHSA is doing, but rather at a federal level, can we at least get our ducks in a row to be sure we're delivering a unified picture of how we are collaborating to ensure that we're meeting the needs of the beneficiary in a beneficiary-centered fashion and trying working, and I think sometimes the silos do need to exist. CDC is a hell of a lot better at doing some things than we are, and I think it's not about just saying everyone does everything, but rather trying to ensure that these silos are connected so that we can deliver at the end of the stage, at the end of the dot line between the federal to the state to the managed care plan to the beneficiary, that the beneficiary is really seeing the benefits of all that collaboration and integration, so we're not seeing the kind of fragmented systems we deliver. So whether it's health homes or whatever delivery systems we're talking about, it's the same theme about fundamentally, as we're changing our delivery system, I think it's not a matter of how does population health fit in, but I think for us it's how can population health not be a part of that picture if we're serious about achieving that vision. And so we've been working closely with our partners.
Thank you. Surgeon General.
Great. Thank you so much for having me here this morning. And this certainly is an exciting time period, I think, in the world of prevention. There certainly has been a lot of impetus, a lot of traction from the Affordable Care Act. But let me start with the basics. Right? What does the Office of the Surgeon General, what does the position of the Acting Surgeon General, or soon, hopefully, to be confirmed Surgeon General, really do in this nation? And it really boils down to a simplistic set of responsibilities, but one that are kind of overwhelming at times. One is, as a uniformed career officer, is to lead the 6,800 officers of the United States Public Health Service Commission Corps. So when we talked about constituents, part of it is the 6,800 officers in the 11 different categories: physicians, dentists, nurses, engineers, dietitians, who are embedded in 26 different departments and agencies of the U.S. government. So no one knows about the Commission Corps of the U.S. Public Health Service, yet embedded in 26 different departments and agencies. One would think, if one believed in conspiracy theories, here you have an unknown service that in fact has infiltrated the highest levels of the U.S. government with what? With the prevention message, right? And that's the beauty of the Commission Corps. But the other part of the portfolio of the Surgeon General is, for want of a better term, we say the bully pulpit. We say the nation's doctor. We say, in terms of a job description, is taking the best science available and to translate it, to communicate it with the American public. So the constituents, on the one hand, are 6,800 officers who salute smartly and say, I will follow the Surgeon General. But also, the constituents really are the American public. And herein lies the rub, because what is the message we're trying to give? Now, the Commission Corps has existed now for 125 years as a uniformed service. This year is our birthday year, 1889. Legislation was passed that said we have a uniformed service, the only one of its kind in the world, mind you, as a uniformed service, an unarmed service dedicated to protect, promote, and advance the health and safety of our nation. It's a very unique responsibility and a very unique approach. But from the nation's doctor perspective, what have we really put our hands around over most of our history? It, in fact, is the prevention approach. If we look back 50 years, we have just celebrated on January 11th the 50th anniversary of Surgeon General Luther Terry's first report on smoking. And I want you to go back 50 years because we realize how our world has changed. We reflected on this at dinner last night, that even perhaps 50 years ago at a public health meeting, At a dinner like we had last night, we could have been sitting around with ashtrays all smoking. And yet, I dare say, if someone, certainly on stage or in the audience, were to light up here today, there would be gnashing of teeth, there would be turmoil, and if I did it, there would be a former acting Surgeon General rather quickly. So the world has changed. 50 years ago, the simple terms that came out of that Surgeon General's report was that, and this is a direct quote, cigarette smoking is a health hazard of significant importance in the United States to warrant appropriate remedial action. That was the doozer. Wow. Wow. But you look at this and you realize that that became a battle of a 50-year time period, a half century, where we've made some progress and, in fact, unfolded the whole process of prevention. 25 years ago, we had the 25th anniversary Surgeon General's report on smoking, issued by the legend, by C. Everett Koop as Surgeon General. And if you look at that report, he in essence says what? Says, we've made some progress, yet there's more to go. I'm in the midst right now of reading his memoirs. And in those memoirs, it's a chapter we can take and kind of almost say, wow, he's talking prevention 25 years ago, like we talked prevention 50 years ago, like chances are we talked prevention 75 years ago, 100 years ago. And we're still not there. That's the frustrating aspect of all this. We're still not there. Because I can take his chapter from his memoirs and really submit them to you and say, this is the current state of affairs. Yes, we've made some progress, but we're still not there. Then we have the Affordable Care Act. Affordable Care Act comes in and actually has components built into it, and we've heard some of them in the earlier panel, that talk about prevention. It establishes a National Prevention Council that Jeff had mentioned briefly in his presentation this morning. The National Prevention Council is an entity made up of federal partners chaired by the Surgeon General of the United States. Is it a novel approach? It may be a slightly different approach. Is it going to achieve our goals? I don't know. But we wave the prevention flag yet again, and we say, let's give this a try. 20 different federal agencies, partners. And as Jeff had mentioned, part of the battle early on was convincing some of these federal agencies that although they don't have the term health in their name, that they in fact are party to health in our nation, that they are partners to prevention in our nation. EPA sits at the table, Housing and Urban Development, USDA. They're all there realizing that now they have a responsibility, and this goes back to some of the talk earlier today about workplace strategies. They have responsibility for their federal workforce. But in fact, their policies, their approach to the rest of the nation can serve as examples of a path on prevention that the feds take. So the Surgeon General chairs this. We have a federal advisory committee that Jeff Levy heads up, incredible people on that group, and all of us saying it's worth another try. What comes of this? A national prevention strategy is issued, really delineating the fact that we have priorities. And this is where it becomes intriguing, because the whole issue is it doesn't fall upon the federal shoulders alone. We used to be cocky, perhaps, in the federal, where, we'll take lead, guys. You follow us. The reality is, look, I ask everyone, look at the National Prevention Strategy available online, surgeongeneral.gov. Look at that document and notice that it starts at the individual level. What do I do as an individual for the good of my own health? I then encompass the family level. What do I teach my kids about health? The community level. It then builds up from there, saying we have so many partnerships. The partnerships were reflected last night, I think, in the beauty of getting together and breaking bread together last night. Because we had, the venture capitalist. I love that term, venture capitalist, don't you? I want to be a venture capitalist because it sounds so cool. But the reality is you have an incredible responsibility, and you're taking this upon your shoulders to play a role. We had the academics in the room. We had the clinicians. We had people who work at the state level. All that combined is really the approach we need to take when it comes to this national prevention. This is a shared responsibility. A national implementation plan comes out a year after the strategy came out. What do we focus on? In our federal family, we say, make prevention part of your life. Okay, that's a little loosey-goosey. Number 2, it's tobacco-free. Let's really take the approach in the federal system of going tobacco-free. Let's see how far we can take this. And the third is healthy food, being able to offer that. We have to be examples. My last theme today, and this is where I think we really need to have this conversation, which is how do we really view health and wellness in this nation? I think part of the problem is all these years we've talked about it. We've made some progress. We've perhaps taken some steps backwards. But in terms of how we cherish the concept of health and wellness, I don't think we're there yet. We've been having incredible meetings over the last few years with a Health Futures group that was originally run by the Surgeon General of the Air Force. DOD is heavily involved in this discussion of health. And it's not DOD-centric. It, in fact, poses a new way forward, in my belief. And that new way forward is, how do we treat health and wellness? We need to treat it like a national strategic imperative in this country. We can't just say, oh, health and wellness is important. No, it's a natural resource. It is as important as all the other important functions of our nation for us to progress. And I think we've been giving lip service to it and haven't come out and spoken to the fact that it is that important. We all know, I'm not an economist, you're a venture capitalist, you know the economy is important, right? We have economic leadership within the White House. We have economic pushes. We have economic summits. I don't think we've brought health and wellness to that level of importance. And ladies and gentlemen, it is important. Thank you.
Thank you. Thank you very much.
Well, I can only laugh. I hate to follow Boris, but it is
somebody's got to do
it. Exactly. And Drew, you should thank me. But I do want to thank you for inviting me to participate today. As Will mentioned, I am a recent transplant to the consulting world, having spent the last 10 years in the Senate and then more recently in the administration. And I completely agree. I mean, this is just such a historic and landmark time for health broadly, and certainly for prevention and public health. Through my time at the department, I was the HHS lead on Let's Move in the Childhood Obesity Task Force. I was able to be the lead on the President's Food Safety Working Group, certainly helping, again, representing the department, the Councilwoman and Girls. I mean, there was just so many different initiatives with leadership at the very top, and usually that means the president, but this time, in this context, I might give a slight edge to the First Lady, never to be repeated. But we had leadership at the absolute top and with broad participation. And I think we were able to get just make significant strides through the first term, and this is certainly continuing on the second. But the question is certainly in terms of who owns this, or how do we advance this agenda, or what are some of the considerations? And I think one of the key factors, certainly in HHS, and what you're seeing here today, is that Secretary Sebelius really instituted a health in all policies approach, meaning that CMS had a role, and I think that many would agree this is a newer role for CMS, new leadership, new interest, if you will. And as a side story, that I think when ACA passed and they had the funding for the childhood obesity demonstration for CMS, technically, and without any real consideration, of course, this is why not being in the administration, I can speak a little more freely now, but not certainly without much discussion or even thought, we automatically decided that the CDC would design a program to spend the money, and we were all taken off guard and quite surprised when CMS said, "Whoa, actually, we had planned to do that," and this was was really surprising for the budget office, for this HHS, this, that, and the other. But I think that was a good sign. It was also, if you think about ACF, the Administration for Children and Families, and they, for the first time, started thinking about, well, we have leverages too. I mean, we could look and see what's happening in childcare. That's our constituency. Or in terms of thinking about obesity in schools, or what can we do through home visitation programs? Or, that's another example of not the usual traditional ally, if you will, within HHS for a number of prevention and public health issues, but they had a role to play too, and Secretary Sebelius really encouraged that, very much encouraged that team approach. In addition to the integration of kind of public health in all policies, all programs, all agencies, this administration certainly, I think, has prioritized relationships with industry and philanthropy. And as part of that, through my current role at a consultant organization, is trying to think about what are some of these partnerships, or how can industry, how can the private sector really play a role. And I think for some of the biggest players, they're pretty advanced in their thinking, but even for some of the smaller players, and even not even for industry, but for some of the smaller philanthropic groups or organizations, they are still struggling to figure out what is our role in all this, because we see that this administration, or even more broadly, is starting to understand that we all have something to contribute, and what can we do. And so that has actually been delightful. A number of people have reached out who want to talk about prevention and public health and disparities and a whole range of issues. What has been somewhat distressing, just in terms of my broad dealings outside of the Beltway, is how many people still don't fully understand the ACA. I mean, we really are quite behind still in that. And also, frankly, in terms of prevention and public health and the data, is one example. One of my clients just mentioned as an aside, well, we really don't have any evidence-based interventions to tackle obesity. And I was somewhat floored, because this was not, I would have considered this to be a pretty savvy stakeholder group. And I was like, well, what about the guide? And, that was new information to them. So that was just an example of that as much as progress as we have made and that we think we've made, certainly I'm seeing even more so now than when I was at the administration, as I deal with more probably representative organizations, how far we still have to go. And so I think that's part of the importance of what certainly the Commission is doing, the importance of all of us and moving forward. And I hope that we can talk more about that throughout this panel.
Let's do that. Thank you. Drew.
All right, well, I'd like to thank Dora for being my buffer, but you kept the bar raised pretty high. But thank you to Vitality and to GW for having me here as well. And I'd be remiss if I didn't say a specific thank you to Jeff Levy and the Trust for America's Health, who has been so committed to the role of public opinion research in pushing the prevention message forward. We've got a lot of people in this room who are experts in prevention and public health policy, and what I'm going to ask us to do is for a second take a step outside of this room and talk about what the other 300 million Americans think, and more importantly, how do we leverage all of the enormous ideas and talent and knowledge in this room in a way that resonates with the people that we need to deliver that information to, and drives change in behavior and policy and political change. I'm going to start with the good news, because I find that to be a good tactic. The good news is people like prevention. Prevention is incredibly popular. They're with us in principle. We've asked this question a number of ways, and we've always done it. We've tried to put it up against the most robust test that we could, and so we've framed it. One of the questions that we've asked consistently over the course of several years is framing investment in prevention around federal spending. Do you think, we went out, we asked people, whether it's registered voters in the country, the national adult population, we asked them, do you believe that we should increase our spending in prevention, or should we decrease it, or should we keep it about the same? Consistently, 67, 68, 70% of people say we should increase our spending on prevention. It's a data point that crosses party lines. And there's very little partisan gap here. There's almost no drop-off from Democrats to Republicans in terms of favoring increasing investment in prevention. And if anybody in the audience can give me 3 other issues on which Democrats and Republicans agree in terms of government spending, I'll give you my wallet on the way out. So it speaks to a broad consensus in terms of where the public is on prevention in concept. One of the other questions we asked was around ACA, and we talked about, here are several different components of the Affordable Care Act. Which do you think should be the biggest priorities, or which are most important to you? And at the very top of that list was investing in preventative health measures. It trumped the idea of preventing insurance companies from denying for pre-existing conditions, from dropping people when they get sick. It trumped the idea of tax incentives for small businesses to provide health insurance to their employees, which are fundamentally, from a public opinion perspective, the most popular parts of the ACA. So it is. People are with us. They're there in principle. And I think the question, to speak to the Surgeon General's point, is, well, why aren't we there yet? I mean, if this is the case and everybody's with us, then there's probably no need for this panel, but there is. And I think we'll get to talk about what some of those obstacles are, but for a second I want to talk about what we've seen in terms of how do we sort of harness all of this and communicate it with the public in the way that's most resonant. I want to make 3 points. The first, and I find this, I'm going to say it first because I think it's the first thing that we have to do. It's not necessarily the most important. It's not necessarily how we win this battle, but it's something that if we omit it, we do so at our own peril, and we don't even get into the conversation. That's personal responsibility. We talked about this as well. People believe that the role of being healthy rests with the individual. That is fundamentally true. We ask people, 80% of people say that they have control over their health. And I should say, I'm speaking outside of policy or what we know to be fact, but this is public perception. 80% say they have control over their own health. And when we do this test, we have a forced choice exercise, and I'll try to explain this in a way that hopefully makes some sense. But I like to use these forced choice exercises. I'm going to read you 2 statements. Tell me which one you agree with more. Force people to make a decision. When we ask a question with sort of the prevention message by itself against, the other side of the coin is that people are capable of making their own decisions and they have the responsibility to make healthy choices that are good for themselves. When we ask that, we lose that debate by 23 points. When we take our prevention message and we start by saying, look, everybody's got some responsibility for keeping themselves and their families healthy, but there are things that we can do to help people make healthy choices. That closes that gap entirely, and we break even. Now, there's positive and negative in there. The positive, obviously, is that acknowledging personal responsibility gets us into the debate, gets people to listen. The other side of the coin is that we still basically break even on this measure. We're pushing against a pretty big wall here. So then how do we climb that wall? How do we get over that wall? The second part of the message here is kids. And we've tested, for lack of a better term, it's kids. We've tested a lot of different messages in a lot of different ways. And the one consistent finding that we see is that when you frame this message around children, it works better. And that's, look, I'm not going to sit up here and say that's not true of a lot of issues. It is. But in this particular case, I'm not talking about, babies and puppies and making it sound great politically. There are real tangible reasons for why this works in a public health and prevention context. The first is it pushes back directly on the notion of personal responsibility. Nobody thinks that a 7-year-old is going to go in and make the right choices about what they eat for lunch every day. And 2 is it takes us, it's very easy to translate this to an aspirational frame. And this sort of leads into the third point I want to make. But when we talk about kids, we're talking about the future. The reality of the situation is, we want everybody to have good health, but the reality of the situation is that you're going to find very little empathy for the person who has smoked all their lives and now 70 years old and has emphysema. There's not a lot of public empathy for that case. But it does take, when you talk about kids, we say, well, look, this is a problem. 2/3 of the kids in our country are overweight or obese. And by the way, 80% of the country knows that and believes it to be true, that childhood obesity is a serious and growing problem. I don't think that stat is going to surprise anybody, but it also speaks to the point that we don't need to define the scope of the problem for people here. People understand the problem. What they're looking for is the solutions. And so the third part of the message here is focusing on those solutions in an aspirational way. And I'll give you one example. We did some focus groups a couple years ago where we tested print advertisements essentially around different public health issues, and we gave people, they had 8 or 9 of them in front of them, and almost all of them, I think we sort of went into this with an idea that we had to underscore the scope of the problem, and a lot of them focused on that. Here are these huge major problems, we got to do this or we're going to be in major trouble. The public didn't respond to those. What they did is they picked up the one of the kids running around on the playground. They look at the clips from the NFL Play 60 ads. I think are a great example, that are upbeat, that are positive, that show that we can succeed on this measure. People don't want to see, they don't want to hear about kids. They don't want visuals of kids with Cheetos bags and Twinkies laying at their feet. They understand that this is a problem. What they want are the solutions, and they want the idea that we can succeed on this. And I think you see a lot of that in First Lady's rhetoric and program, and I think that's sort of the direction we're headed. So,
thank you. So you want to be a venture capitalist?
I don't even know what that is. But it sounds very cool.
Well, so in venture capitalville, everything's about faster, better, cheaper. Mm-hmm. And so when you talk about 50 years, that's 2 generations or more. That's a long time. And then you also talk about with health, you talk about easier. We have a lot of evidence showing that when things are easy, people adopt them. The companies that are being sold for billions of dollars have one feature: text. Mm-hmm. It's remarkable. So listening to our legal scholars this morning, my head's spinning, thinking, how are we going to interpret this very complex law? And how are we going to take these very complex systems and make them easy? How are we going to speed this up? We don't have another 2 generations, right? You won't be happy if your successors in 50 years talk about, life's moving a lot more quickly. So I'm really interested, how does Washington, D.C., which is the bedrock of all the ironies of democracy, where things move slowly on purpose. It's designed to, really. I mean, it's our system. But how do you guys innovate? How are we going to speed this up? How are we going to make it easier? What are you working on that would inspire our audience today?
Well, one thing I would mention is that one of the things that we need to prioritize is making a better job of pushing the resources that currently exist out there. I mean, even from the first panel, when we were talking about employers, particularly small employers, what can they do in terms of worksite wellness? I mean, CDC has worked in this area. There are actually manuals and resources and toolkits for employers. Like Lean Works is, I think, one of their primary toolkits for small businesses to what they can do to help in terms of workplace wellness. And yet that's not commonly known. And I dare say, if you ask the majority of businesses, they might not know that it exists. But Bill Dietz, certainly, that was one of many issues that he focused on. And so that would be, and that's just one of many examples, certainly. But I think
underutilized resources.
Right. And so it's not quite the same as translational research in terms of what was also discussed, but just really putting things into the hands of everyday people.
Is that a different capability than exists? I mean, is that an opportunity for partnership, or how is that going to come about?
Yes, I do think that is an example of how maybe government could improve its dissemination efforts by partnering with groups that have closer links to the business community or the provider or industry community, whatever the case may be. But some of the networks or clearinghouses or the current channels are clearly not maximizing the opportunities that otherwise could be out there.
So I think that's a great point. I think that the idea of dissemination, I think, is key. I think that the underlying message underneath there, and I think we've done at least, and I'll speak for the Medicaid side of the shop alone, but I think I'm the Chief Medical Officer for Medicaid. I'm also the first Chief Medical Officer for Medicaid, and I think I say that only because it is that orientation shift that Dora was talking about. Is this recognition that we can't just pay the bills and expect to have good outcomes, that we need to do more and be better engaged. So some of the work that we've been doing is exactly as Dora's talking about. We've put out more, state Medicaid director letters, informational bulletins, more how-to statements about how do you engage in delivery system reform, how do you think about a superutilized program, how do you think about integrating behavioral health into your vision, what does it mean to tackle quality in the context of your Medicaid program, and we're just continuing to push out a steady stream of those for our state partners, and some of them with some success, others with not, and I think we're just going to continue to look for those keen opportunities, tobacco, and continue to look for those areas where we know there's delta to be made here. And I think that's the message that we're trying to deliver to our state partners. I think there's a beneficiary message. For us, we have to also deliver a message to our state partners. And that message is opportunity. And I think ultimately it is the idea that there are things that can be done here. Commonwealth Fund did a report a few weeks ago on state scorecards and found fourfold differences in terms of quality metrics between states, quality metrics that we know how to improve, some of them population health metrics. So it's this idea that we're leaving stuff on the table here. Look, state X is doing this. You know, when you think about this from a QI perspective, the Six Sigma, Lean, all those buzzwords, variability is always the hallmark for a system that's ready for change. Mm-hmm. Well, we have that in Medicaid. We have that in our health system. And that opportunity is so keenly apparent to our state partners. We're having a stream of people coming out in the door to talk to us. doesn't hurt that we are offering in some cases to restructure some of their financing so it frees up large sums of money for them to make some of these front-end investments in the promise and the expectation that there'll be back-end returns. And I think we have some of those deals that we've been working out with states. But I think we've been also more forward-leaning in terms of saying, look, if we can do this right, we are actually very much open to these kinds of efforts and deals. And so it's resources, it's dissemination of information, but it's that communication fundamentally to say, there's opportunity here. We're ready to put our dime on the dime. We need you to as well, and we're ready to work with you.
That's very helpful. Our commissioners are very thoughtful and sensitive about language, and we're going to spend the next day and a half refining and reviewing our draft recommendations. And I'm always listening, trying to carefully listen sort of for the vocabulary and mental models, that are coming together. And one of the things that struck me about this panel is no one has used the word patient, which I think is kind of profound just in terms of the way the word health and patient have been synonymous for ages. And, so I commend all of you as spokespeople for this culture of health that we're all trying to support. And I think it's empowering to individuals to not be labeled or thought of as a patient in a system, but actually to be a well-being.
Well, and it goes back to the whole concept, built into the national prevention strategy is really this, another attempt. And I have to be honest, I'm not naive enough to say that oh my God, the National Prevention Council, the strategy is going to change the world. I have to be an optimist. Like everyone in public health knows, you don't survive in public health unless you're an optimist.
And venture capitalists.
Right, and venture capitalists. That being said, it's really going from that focus of our emphasis on diseases and illness versus the idea of health and wellness. And I think that, by definition, takes us away from the patient realm. The patient's always going to exist. I mean, medicine is not going to go away. Healthcare professionals are not going to go away. But can we decrease the burdens that come with disease and illness? That's really the point. I think one of the other things when you talk about sort of the time span, and I realize this is where our worlds may be quite divergent. You're a venture capitalist. You want return on investment soon. Otherwise, what happens is the investors go away disappointed. In public health, specifically with complex public health issues, I really have to be realistic. And the realism that has to be introduced here is I don't see turnarounds in a year or two, right? I don't. And I think all this time we've somehow felt guilty about that, right? One thing that everyone should do, just to get enthusiastic about it, is look at the Morbidity and Mortality Weekly Report published in 1999 that showed you what? Showed you the 10 major public health accomplishments for the 20th century. It's a 100-year time span. And it's unbelievable because what you say is, in that 100 years, we made incredible progress. Smallpox, 1900. Smallpox, 1999. Recognition of things such as fluoridation of water. That's a preventive measure. We sometimes don't think of dental public health often enough. But 1900 versus 1999. Automobile safety, occupational safety and health. That's 100 years, folks. And I think sometimes we put undue pressure on ourselves. Why? Because we sometimes think like venture capitalists, which is tomorrow, tomorrow, tomorrow. I need to depressurize ourselves a little bit, which is let's make that advancement. Let's take those steps in the right direction. Let's, again, two things I put out in my opening statement. One is I don't feel we've prioritized this enough, so I need to raise it on a pedestal. I need for the White House to actually say that this is important, that health and wellness is important. We've seen it in the First Lady's perspective. We need to get more of that. And then the whole issue of funding. We've talked about secret, oh my God, there's no funding for prevention studies. What works well? Well, let's not whisper about it. Let's go out and boldly say we have a problem. And the problem is I have to look at the evidence base that exists out there so that the venture capitalists can say, okay, there's something proven. So that the workplaces can say, okay, we can implement this because someone's proven something. We're very much behind the curve on that.
Could I push back on that a little bit, though? Yeah. Not that I would ever dare take Boris on, but just a little devil's advocate. Exactly. But I will say, though, that was one of the major sources of tension in the first administration, the first term, was how to balance the need to be pragmatic and realistic. It's going to take years and years to finally change the community, the school, the work site, whatever the factors that will lead to decrease in obesity, rates of obesity. And then those that didn't know all that, who are coming new to this and are saying, why? But we must go faster. And, well, then how can we go faster? And they absolutely refused to accept that. And I think, though, I was completely on the other side. I've actually started to appreciate their viewpoint in the sense that, well, we know what we can do. We know what can be accomplished when we do what we've always done. But now we're here. We have this new leadership. We're putting resources. We're going to marshal all of the talents across all the different departments and agencies. And we're going to see how we can change this marathon into a bit more of a, I don't want to say sprint, obviously, but see how if we could do this a little bit faster. And also engage all these other non-traditional and historically unwilling partners to the table. And so I think some of that viewpoint, which was so painful, because you're always fighting against those that say we're going to decrease the rates of tobacco by 10% this year, that type of thing. But at the same time, though, it did kind of help challenge you and push and say, are we absolutely sure that this is the best that can be done? Mm-hmm. And why do we think this to be true in the era of, in this era, particularly with technology changes or whatever the case may be? And so I appreciate that more now and think that's something we have to keep in the back of our head.
Let's follow up on that, because there's a distinction between a long-term perspective and patience. Right. And then there's also an urgency about using the tools that we have. And Drew, I mean, we're living in the world of Twitter. This conversation is being live streamed to hundreds of people that aren't in this room today who are joining us. So what are the opportunities that at this threshold where the health system's changing, technology's changing as well, especially around social and cloud and mobile, and what are you learning around that?
Well, on the opportunity part, I want to sort of go back to this last conversation because it's an important point, and to another point you made about language. But I mean, I think both of the points that Surgeon General and Dora made are both can be true. I mean, we actually asked a question at one point about the Let's Move program and the goal for the Let's Move program of eliminating obesity by 2025, 2030, whatever. But it was interesting that people actually believe this to be a realistic goal, and you could actually view that in both of the ways that have been discussed out here. Like, on the one hand, it's a long way away, and this was a couple years, and maybe it was 15, 20 years into the future. On the other hand, that's pretty incredible. I mean, that is a huge, huge goal for people to say, 60, 70% of the public to say, we can actually accomplish that in 15 years. So I think I think both of these things can actually be true. I think you do need some urgency, and I think you also do need some patience. And you see these trends, to get to your point on language, you see these trends emerge over time. And one of the questions that we'd asked, I want to sort of give you two data points here, but one of the questions that we've asked, and there's actually data on it going all the way back to the 80s, is do you think that we have the right emphasis do you think we should have a higher emphasis on prevention, higher emphasis on treatment, or do we have about the right balance between the two? If you go back into the 80s, it always tilted toward people want more emphasis on prevention, but you saw a steady uptick in that number of people wanting more prevention up through the last couple of years. All of a sudden, we saw a pretty rapid drop in that increase in prevention. And part of this is because people are starting to internalize what prevention is. When you talk about language, and the point I want to get to is, we asked a question, this is the second data point, a year or two ago, where I wrote it down so I got the language right. But the question was, which of the following do you think would have the greater impact on helping people stay healthy? Improving access to safe places to exercise and get healthy food, or improving access to quality hospitals, doctors, and nurses? So we were essentially pitting community versus clinical here. And this is one of the things that we've always seen in our research, is that when you talk about prevention, what people talk about is clinical. They say prevention is doctors, having hospitals in my community, access to health care, community clinics. There's a degree to which it's a very vague concept generally, but when they do know it, they sort of view it through the lens of clinical. Where I think, to your question, Will, where there's an opportunity here and where things are changing is that we're starting to see those lines blur a little bit, and I've heard it both in qualitative focus group research, in which we used to ask, we'd say, talk about prevention, whatever the question was, and it would be all clinical, and they'd stop. In the last couple of years, what we're now seeing is clinical, and then, oh yeah, they also built a new bike path in my neighborhood, or the streets are safer. All of these things are starting to become part of people's construct of health. And the data point that I want to give you is, we asked this question on the one I just mentioned. I fully expected this to say, well, the most important way to stay healthy is for people to have access to doctors and hospitals and nurses. It was 41 to 41. I was stunned. I had them rerun the data 3 times because I didn't believe it. But it's borne out in
20%.
It's well, I mean, there's a both or neither category, but I mean, the point that we are sort of making ground on this issue or gaining ground on this issue and changing people's construct of what health is and where it can, and I'm not saying one is more important than the other, they're both incredibly important. I think what we want to do is make sure that community health approach is clinical, and I think that is where we have a big opportunity, where you're starting to see things change and where we can also push this forward.
We're going to take a couple of questions from the audience. We're a little bit behind schedule, so if you have a few extra minutes, we're going to keep going. I see Kevin Volt. Can we bring him a microphone? Or can you come to the center? Or Kevin is one of our commissioners.
Thanks, Will. I'd like to ask all the panelists a question. One of the things that's puzzled me for a long time is that, on the one hand, CMS is not allowed to consider cost and coverage decisions around treatments. On the other, when CMMI asks for innovation, new ideas, there's a very high standard for basically proving that the interventions are going to save money. And so it's always struck me as this unfortunate situation where there's one standard for evaluating preventative or delivery system innovations, which is not only do these improve health at a reasonable price, do they actually save money in the short term, which is a very hard bar to meet. On the other, when it comes to treatment, no expense is too great, and we even pay for things that are Preventative Services Task Force D, like PSA screening. So it doesn't make any sense because it obviously leads to overinvestments in treatments, underinvestments in prevention, and I'm wondering if those of you who are more familiar with the inner thinking at HHS could talk us through how that makes sense.
So I'll start, and Kevin, as usual, I couldn't agree with you more. I mean, I think that it is a challenge. I think that that was what was striking me in this last conversation in terms of it's a uniform value proposition is what we should be thinking about, not what does it mean to have $50,000 per quality for a cardiac intervention ICU versus has to be actually cost savings. Never mind that it's a minimal expense, actually cost savings for prevention. I don't understand how we've all gotten ourselves in this box to a certain degree, but here we are. And I will say that it is true that CMMI, the constraints are as you described, and I think part of that was under the impression not that every individual service there had to be cost savings in and of itself, but rather as a system could say, look, I'm spending way too much money in the ICU. Maybe we should be sending some caseworkers out to the communities to get those high utilizers before they come in, right? So it's not necessarily that caseworker, as I don't tell you this, but cost effective as compared to what? So that caseworker may be an additional expense on their ledger line. It may be, according to CMS, an additional benefit that we pay for. But from the CMMI perspective as a whole, this may be a cost-saving venture. Now, having said that, so I'm making a case for why CMMI's strategy makes some sense in the context of some delivery reforms. I will say from the Medicaid perspective, and I think there has been some confusion about this because we just issued a rule last year that said we would pay for instance, for a long time, we, like Medicare, would not pay for practitioners that delivered services. I think Naomi talked about this a little bit, unless there are doctors, essentially, licensed practitioners, not only doctors, but other licensed practitioners. What we said in July, in response to a lot of comments from a lot of people in this room, was to say that we will pay for services, preventive services, if they're delivered by people who are qualified to deliver those services, but maybe qualified that don't have a license. That recognize that licensure is not the only bar for this. And I think this is an important flexibility for things like obesity treatment, DPP, Diabetes Prevention Project, all sorts of stuff like this. What we've heard from, I'm getting to the point here, what we've heard back from our state partners is we don't want to do this unless it saves money from some of our state partners. We from CMS are not putting that constraint on. States are always free to add stuff to their benefit package so long as they're willing to put the match rate. We'll match that so long as it's a medically necessary service, all that sort of stuff. But what we're finding out is that our states are taking that value proposition as a cost-saving proposition. And I think we're trying to broaden the conversation a little bit to say, look at this a little bit broader. And I think we're trying to engage in that conversation. But, so I would say, to your point, whether it's statute for CMI or whether it's just the reality of the way some of our partners, at least within the Medicaid space, are looking at this, and I would include some plans in this as well. We are in a bit of a box right now. I think it's incumbent upon all of us to continue to write and publish and put these on that framework of a unified value proposition. I think that's a great op-ed piece that we should be thinking about.
Mm-hmm. The only thing I would add to that is that certainly there does seem to be a difference between CMS minus CMMI, but over time the delivery system reforms and methodologies that are found to be successful through CMMI testing can be permanently extended or adopted by CMS without having to go back to the Congress. I mean, that was part of the ACA statutory authority. So I do expect to see some of the innovative practices identified by CMMI to be integrated throughout Medicare and Medicaid program.
Almost a scoring issue when we were trying to pass it.
Mm-hmm. You satisfied with the answer, Kevin? Okay, never mind.
You should be.
I'll talk to you later.
That's a fair statement.
Rajiv, did you want to ask a question or make a comment?
Thank you for the
please?
opportunity. Yeah. Sure. I'm Rajiv Rimal. I'm the chair of the Department of Prevention and Community Health. So as you can imagine, what I'm hearing this morning is music to my ears about the emphasis on prevention. And based on both the conversation that we had this morning in the earlier session as well as the session now, one thing that appears to me is, particularly as someone who is very interested in how we communicate about health and wellness to the general public, is, we've talked a lot about what social marketers would call the demand side. We've talked a lot about providing services, about providing compensation, etc. We haven't talked as much about the demand side. I'm sorry, did I say that backwards? Yeah. We've talked a lot about the supply side. We haven't talked as much about the demand side. And that, if we think about health and wellness as away from an absence of disease model, I think it gets to some of the issues that on the demand side are very relevant, like, how do we create a particular kind of culture that we talked about of health and wellness? How do we talk about certain kinds of norms that, as the Surgeon General gave the example of smoking, if someone lit up here, we would immediately slap that person down. So we've come tremendously long distance in terms of creating those kinds of norms. And I'm always baffled by how when public health communicators talk to the public, it's usually dark and dingy and don't do this, and they're shaking their fingers, and if you do this, all these horrible things will happen. And yet, if we look at, if you're a producer of a product that kills people, that makes you smell bad, that costs thousands of dollars over your lifespan, they present it as a sexy thing, right? You've come a long way, baby. And so when really bad products are being marketed in such a fashion, we in public health are countering with these very dark and dingy kinds of messages. So I'm wondering if the panel could talk a little bit about what can be done on the demand side so that we do create this culture of health and wellness.
And part of that, my predecessor, Dr. Regina Benjamin, would always talk about this in terms of, the perspective of, you're absolutely right. I mean, we spend a lot of time in public health saying, don't do this, don't do this, don't do this. And her approach, and her background was really a family physician. She had that patient context even when it came to dealing with the public's health. It really was sort of a switching of terms. And whether it's a shell game or not, I don't know. But in reality, it's the concept of what can you do as opposed to what can't you do. And maybe it's a reframing of the messaging. The second concept that we have within the National Prevention Strategy is, and that's one of the important tenets, is the concept of empowering people. Now let's be honest. We like to say that, and it goes back to our American roots, right? Which is, I have free will, I have the ability to decide. I think we in public health have an obligation to actually take that, right, for what it's worth, right? That is a reality of our American philosophy. But that our goal needs to be that by using that term empowering people, we in essence say you have all the choices in the world, but however, I have given you enough information. You have taken that information in so that you inevitably make the right choice. Right? That's what we're trying to achieve here.
I mean, that is exactly right. I mean, it speaks to the notion of personal responsibility, and we see it when we test different measures, on the demand side of things. The very prescriptive measures, soda taxes. I mean, you saw it in New York City with the 16-ounce soda ban. I mean, these prescriptive measures are not nearly as well received by people as the idea that, look, you have the ability to make the decision for yourself, and you should make the decision for yourself. What we're going to do is provide you with the resources to be able to do that. And so I think when we look at some of the things that sort of force good health upon people, that's when you're going to get people pulling away. I think the other part of the story here is one of the main things that we run into here is cost and accountability. And the reality is there is a level of distrust in the federal government right now that is greater than probably at any time that there ever has been. And I think we need to work on how do we establish the idea of accountability, the notion that we're going to do this in a way that makes sense. And one of the things that people tell us when we're talking to them in public opinion research is, they like the idea of this stuff coming to them at the local community level. And we need to get into a situation in which people believe that this is something that is going to be driven by the local level, be driven by partnerships in their community, because at the end of the day, what people care about is the outcome. People think about this stuff in terms of, am I going to be healthy? Is my child going to be healthy? Are they going to have a good school lunch? All of these things. They care about tangible, specific things, and we need to, I believe, talk about what we're doing in very tangible, specific terms that a mom will understand.
And maybe that's the answer to Kevin's question, and I think because I remember having a meeting with some of my fellow partners in the federal government, and they were just trying to get us more involved in an issue, and they say, well, CMS can do things here. And then finally, what do you want us to do, right? It wasn't, there was no concrete action. And I think in sympathy to our state partners who are often giving this pushback, I think that value proposition isn't just saying it's valuable, right? It's saying here's what you get for it. So if we want to move out of that cost savings only model, I think we have to be willing to commit. And I'll be honest, I haven't always seen that from a lot of my friends in this room when they're coming to us to talk about stuff. That concrete, tangible evidence of here's what you get for that spending, right? And so I think it's a challenge also on us as we make our pitches to think about what does it actually mean if we want to make that pitch for spend more, what do you get for that, and being very concrete about that side of things too.
Thank you. We've got some incoming questions, do we, Elle, from the
we
stream?
do have one from Twitter I can share.
Sure.
How do we communicate confusing things like coverage to patients and providers while conveying the nuances?
Okay, well, thank you. That's the $6 billion question, I think, at least. Or was it $19 billion? Have you ever heard of what app, Surgeon General?
Yeah, $19 billion today, yeah.
Okay, we'll talk about it later.
Yeah.
Right.
How about another question? I'm sorry, it's hard to see here.
I'm Ann Sebold, and I work for a firm that does communications, and I've worked in behavior change communications for a long time. And what feels missing from this conversation is that conversation about the communications, because there's a value proposition in the behavior change communications that's not about the intervention, that's about making it, Bill Smith said, easy, fun, and popular. and I think that's a huge missing piece today, and we're not going to get there without it. And I think it's important to know what public opinions are, but it's also important to know what's going to make this behavior change. And I have one quick question about, when you were saying earlier about the delay, are you talking about delay because we don't have the evidence-based interventions, so we need to get those before we start, or is it the delay about how long we know it takes to change behavior?
From my perspective, I think you hit the nail on the head, which is, I talk about delay, and the perspective is very 20th century, which is using those tools that I've had in the 20th century. What I don't have is the senses, and it goes beyond evidence-based. It goes into exactly what you're saying, which is what are the current capabilities of the venture capitalist, of the communications people, of the new tools that we have, the evolving tools, and how effective will they be? And this is akin to smallpox eradication, right? Smallpox eradication took place because tools were developed, strategies were developed. The whole idea of vaccinate in a ring pattern around the cases, right? That was a strategy that basically led towards public health success. Right now, we're in the 21st century. We need to capitalize on those 21st century tools to realize which ones are the effective ones to be able to decrease that presumed time limit. So to some extent, I'm protecting myself to say it's going to take me a while, but if you in the communication field can say, no, I got something that works, I'm willing to say, man, then we got to partner on this, right? Because then we can bring it down not to a tobacco-free generation in a generation, but maybe a tobacco-free generation in half a generation. And therefore, we have a win-win situation.
I think your point is really well taken. It's something we're very sensitive to at the Commission. We think a lot. We have a communications team that's really thinking about how are we going to translate these recommendations into actions for implementation, who are they going to be delivered to, in what way, what message. And so anyway, if you want to help us and you have suggestions, we are completely...
And one thing we didn't touch upon, which let me just introduce, because again, it's too bad that we're always time limited, but in reality then is using those new tools is that access to all, right? We have not mentioned the term health disparities here, but in essence is, although I'm presuming that we're in the 21st century, we know we have communities within these United States that aren't there, right? We have populations, we have underserved and vulnerable populations to which we have an obligation. And the question is, if we come up with the right answer, does it cover 100% of us?
And I think there's broad acknowledgement that better communication tools are needed, and I think that the administration certainly has made some steps in that regard. And as one example, I know we touched on the NIH earlier in their role, but they maintain and have developed a number of everyday text messages, for example, or content messages that are oriented to the public and to the individual. And you can also point to the Text for Baby initiative, which is another HHS partnership with industry and a number of other advocacy groups in terms of, is this a way that we can communicate to important messages to patients? I hate to say patients, but to in this case pregnant women, in ways that we will actually help to incentivize them to take whatever action or ask whatever question is needed. So, there's certainly a sprinkling of efforts, but to the extent, to your point, that's needed in a much greater and cohesive fashion, I think that certainly is something that needs to be a higher priority.
And I think there are best practices.
Yes.
I think there is a lot of work that's been done, so it's just a matter of bringing those two things together.
Mm-hmm. Yes, and I think Robert Wood Johnson Foundation's actually sponsored quite a bit of research, even on language and messaging. And this has been such a fascinating conversation. And Surgeon General, I think you've got all the makings of a venture capitalist. You've got to be patiently urgent.
There you go.
And pathologically optimistic. So
well, here's my card.
Can we have a big hand for our panelists?
Thank you.
I'd like to share just a few minutes about the Vitality Institute and the Commission, and I also want to really again thank Dean Goldman for hosting us here today, and for all the people on the Vitality team who've worked really hard to make this event possible, and a special thanks to Jeff Levy, who's been instrumental in really helping us cast the stage today with such notable and thoughtful presentations. Let's see if I can. So the Vitality Institute was formed early last year, about 12 months ago. We're an impact-driven research institute dedicated to the prevention of chronic disease and the creation of a new culture of health. We're focused on working-age Americans. Our work is intended to be complementary to the work of other commissions that have been focused in this area. There's been a lot of work done with children and communities, and our work specifically is going to focus on working-age Americans. The premise that the Institute and the Commission are embracing is really that the short and long-term economic competitiveness of the United States is directly linked to the health of our workforce. And there's substantive data now really illustrating this. And we want to just really make this point. We believe that in our society, which is driven by a marketplace, a democracy of capitalism, that people understand that they want our nation to thrive. They want our nation to lead. And in order to do that, we're going to have to be healthy. We just cannot afford not to be healthy if we want to thrive in the future. The commission is made up of about 25 commissioners from disparate backgrounds. One of the design principles was really to bring this very diverse group of expertise, different vocabulary, language, perspectives, ways of looking at the world. And we've just created a very interesting dialogue. Many of the commissioners are here in Washington today and are going to be reconvening right after lunch to really roll up our sleeves and work hard. We've got a first draft of our recommendations, and I'll share those with you in just a minute. The Vitality Commission has been pursuing gaps in the evidence. It's really an evidence-based initiative. And this afternoon, we're going to be reviewing the papers, which we put into kind of academic scientific posters, and we're going to debate them. We're going to have kind of advocates and devil's advocates debating whether we're on track, whether there's still gaps in the evidence, whether the evidence is going to accrue to powerful arguments and recommendations. We're going to release this set of recommendations in May of this year. We're going to have an event in New York in May 21st. We're working to really identify leverage points. We know we can't do everything. Sometimes it's incredibly overwhelming to think, even to the Surgeon General's last point, is that if we can't include everyone, that should be a noble and meaningful aspiration, but we also have to think about what can we do now? What can we do with what we've got? So we're trying to bring together the deep, thoughtful kind of approach of an epidemiologist with the sort of urgency of an entrepreneur. And we want to really create, we don't want to just deliver a book of words that'll be dead on delivery. We want actually something that's going to catalyze action and create real impact in society. So we're thinking about this with a systems approach. We're thinking about our different constituents, the individuals, or in the words of CMS, beneficiaries. We're thinking about communities, courts, businesses, universities. We're learning a lot that empirically change happens at an individual and a local level. There can be lots of encouragement, incentives, and structures and reinforcements, but fundamentally this health thing is happening on a person-by-person basis, family by family, community by community. Some of the things we're seeing in food are just so illustrative of this. And we're trying to incent and encourage this cross-disciplinary collaboration amongst our commissioners and then all the communities in which they inhabit. You know, I'm a gardener at heart, and I think about things in an ecosystem. And when I think about our health care system, I often get the image of like a stagnant pool of water. It's been neglected. It's dying. But it's showing signs of life. And if it were freed up, it might flow. I mean, this is data that all of you know, but the U.S. is just performing very poorly in health and placing very low in health rankings. And this information would probably shock a lot of people because they think many people think that as a nation we're just exemplary in every way and we're just failing miserably in health. And some of this data is helpful to understand both where we're at and where we could get to be with just the tools that we have. So oftentimes at the Commission, we're trying to embrace this idea, what if we just applied what we already know about what works for health promotion and prevention? We know a lot of things. You heard it here, but we don't necessarily know how to implement it. We don't know how to push it out. We don't know how to innovate. We don't know how to get it engaged. So one of the things we're thinking about from the Commission as an approach is aspiration, this idea of engaging people. What if we got it right? I love this chart. Johanna Getzel dug this up, but this is a projection of obesity rates if Americans engaged in 150 minutes of non-work physical activity each week. So showing the actual and then the recalculated. I mean, I think that's just so powerful and that's so hopeful, and 150 minutes is not a lot. So it feels within reach, and when I look at a picture like this, I think about national transformation. That's pretty neat. So breaking things down that are very large and intimidating into individual activity, I think, is a very powerful idea. So the aim of our commission is to place the power of evidence-based prevention at the center of healthcare policies and actions and funding decisions in the United States. And I want to just share with you quickly our draft recommendations. And I really want to invite all of you who have been so generous with your time staying with us today to think about these and provide feedback to us. And we welcome that feedback either directly today or by email or by any means you want to send it to us. We're here to get your feedback and input. So the first recommendation is about placing prevention at the center of healthcare decisions within government and business. This is elevating health as a strategic priority, as Surgeon General said, and also elevating it really as a cultural value in business. The second recommendation is about developing a strong, organized, collective, and unified voice composed of diverse constituents to advocate for prevention in all policies affecting health. So this is the idea of taking the fragmented efforts and activities and really working in workshops in a concerted way to develop unified and amplified voice. We did this yesterday in a workshop with several small and large companies and workplace wellness experts working on a curriculum that would be accessible to companies. Encourage employers to incorporate health metrics of employees into financial and sustainability reports. This really follows on this 15-year trend of the embrace of corporate America and of responsible businesses to really integrate sustainability measures, to integrate principles of corporate social responsibility into their reporting. And most of the leading companies in the world now are upfront. Many of them are becoming more transparent, and it's starting to shift corporate America and even the marketplace to a longer-term perspective. So we think health is the third leg of this stool behind responsibility and sustainability, and we'd like to see it integrated into the way people measure success in business. The fourth recommendation is to prioritize investment and policies that influence prevention by proposing criteria to evaluate health spending and programs in government, agriculture, and urban development. When I say that one out loud, it's still a mouthful, so we're going to have to work on the wording a little bit. But the idea here is, again, cross-disciplinary, to look at other sectors that aren't directly within the realm of health: agriculture, urban development, urban design. There's opportunities for people that hold the torch and the value of health in other sectors, the way cities are designed and laid out, the way agriculture policy is designed to support healthy eating or to incent the production of healthy food rather than the converse. The fifth recommendation is to incentivize organizations using the power of market forces to create healthy and profitable products and services. And just to kind of go back to the Surgeon General and my teasing of each other, I really think it's not the venture capitalists that are important here. It's really the entrepreneurs, it's the innovators, and they're not just in Silicon Valley. They're everywhere. They're in every organization. They're in every institution. They're in every agency, I'm sure. And there are people with great ideas, and we live in a world today where the means to translate those ideas into a prototype or a pilot are more accessible than ever. And we need to be testing things, and we need to be trying different things. We need to be freeing the forces to go out and tackle things that they care about. We have to have public health people looking out for everyone. That's really critical. But we don't want to stop the innovative work that's at hand in front of us. So those are the 5 draft recommendations. There are about 9 important evidence-based studies at work. Many of them will be published as papers, some of them in the Lancet. We're creating a document that will outline the supporting evidence and recommended actions for each of those principal recommendations. And I'm just going to really invite all the commissioners to rest up because we've got a lot of work ahead of us. We've got 2 other forums coming up. We're going to do one in Atlanta in conjunction with Emory and the CDC. We're going to do one in San Francisco focused on the role of food at work as a tool for motivation, health, and maybe even competitiveness. And then we're going to launch the Commission's recommendations in May, as I mentioned, in New York City. I just wanted to leave you with a little story that is attributed to Loren Eiseley, who is a famous anthropologist and philosopher. He was considered a modern Thoreau, and he wrote this story which touched me because sometimes all of this work ahead seems so overwhelming. But he says, "While wandering a deserted beach at dawn, stagnant in my work, I saw a man in the distance bending and throwing as he walked the endless stretch toward me. As he came near, I could see that he was throwing starfish, abandoned on the sand by the tide, back into the sea. When he was close enough, I asked him why he was working so hard at this strange task. He said that the sun would dry the starfish and they would die. I said to him that I thought he was foolish. There were thousands of starfish on miles and miles of beach. One man alone could never make a difference. He smiled as he picked up the next starfish. Hurling it far into the sea, he said, "It makes a difference for this one." I abandoned my writing and spent the morning throwing starfish. So I invite all of you to find your starfish to throw. I also invite you to think about how we can think deeply and act and model the kind of leadership that it takes to prevent the kind of problems that have developed over the last 50 years, many by our own doing. So with that, I'd really like to bring Derek back up to say a couple of final words about the Institute and our work ahead. And again, thank you very much for coming today.
Thanks, Will. And I think the breadth of discussion we had really was quite stunning. And I think, if anything, justified the need for this series of conversations we're having around prevention. I think it was the high quality and the diversity of people on the stage showing that if we actually can harness those ideas, we'll make a lot of progress. I think Will knows that I like sometimes to relook at the starfish story through some other eyes. And sometimes that decision gets even more complex. And my favorite story, which goes, I think, beyond the starfish one, really goes to the heart of the dilemma I think we face often in prevention. And it's a simple story told by the late Carl Taylor, who many of you would know as one of the great leaders in international health at Hopkins for his career of 50 years plus. Carl used to tell us this story and talk about it, I think, in practical ways because he knew the story in reality. The goal is to vaccinate a community of 5,000 or 6,000 kids high up in the Himalayas. Because it's such a complex terrain, you need to assemble the people and plan it months and months in advance. And the kids and the families can only get there for 1 day, maybe 2 days at most, and they will otherwise be dispersed. If you get there and vaccinate them, there probably will be a very high degree of probability there will be no deaths from measles and other vaccine-preventable conditions in the next year. If you fail to, there will probably be the inevitable outbreaks that they have, and some will die. You don't know who they are, though, of course. And as you're driving up with a 2-person team, a car in front of you rolls down the valley. and you see that the driver has survived and is bleeding to death, but he isn't dead. If you stop and take him down to the base hospital, with certainty you will not make your vaccination day. If you leave him, he will with certainty die. What do you do? I think that's the decision that often high-level policymakers are facing every day. And I raise it because many people react in different ways, and they'll try and negotiate all sorts of deals out of it, and there often is no negotiating on this. It is as stark as that often. And some will weigh in then on the visible face of somebody looking in front of them and the basis of the Hippocratic Oath, which starts off saying, do no harm, which would require you to take curative action in the face of that and give lower priority to the faceless numbers of people who you may very well save, but you don't have the great certainty of saving. Others will actually take the alternative view and get on with the vaccination and recognizing the enormous tragedy of the situation. I mention it because think every time there's a crisis out there, that there is no limit placed on the expenditure for a crisis. Yet there is enormous constraints placed, and we heard Stephen Shah talk about the dilemmas and the extraordinary reality that there are cost-saving requirements required for prevention. There are none for the extremes of the most expensive forms of treatment that constitute the 98% of healthcare dollars spent in this country. And unless we're willing to face that enormously tough dilemma, I think we'll continue to actually save individual lives while we continue to have the children dying of vaccine-preventable diseases. I think what I heard here today were three big messages, or three thoughts. One, and I won't go, I'll be one minute on each. One is the extreme mismatch that still exists between the goals of prevention and the means of achieving that. We had great examples of underfinancing of research, the very research required to build the evidence base, to do the investment, to make all the differences. And in the course of the commission, we already heard Jeff highlighting that there will be a lot more detail on that evidence. We also heard some enormous regulatory hurdles. Not being a lawyer, I call these silly laws that are actually hampering the progress on prevention and promotion, often for reasons that seem pretty arcane to me, but I think needs to be addressed quite frontally. I mentioned the fact that we have the undue focus on the proof of cost saving for prevention, yet you may not show cost effectiveness data when you're dealing with treatment, may not by statute in certain settings because of the fear of the death panel stories that arose. And that's why we don't have a nice equivalent in this country, but we have one in the UK. And then finally, I think there's the mismatch is the lack of serious urgency to prevention, and the fact that if there is a crisis, prevention people get pulled out of their jobs to do what is often seen as more important in a crisis. And I'm not saying it's right or wrong, but that's the reality of the way it works. It was Bill Foege who way back said that we always let the urgent crowd out the important. And that lies at the heart of the dilemma we face. That's on the negative side. But on the positive side, we had a stunning acting Surgeon General, and he certainly acted like a Surgeon General, who I think who's bringing the needed passion to the area. And he and many other colleagues, including Jeff, highlighted the fact that this is the time for prevention like no other from the public sector perspective. The ACA creates enormous opportunities, and we certainly in the Commission need to point to those. What we heard is that many of them are hidden away. Many informed people in this audience seem to be unaware of the provisions of the ACA on many aspects of prevention. I certainly remain amazed every day about learning about new ones. And we heard about a lot of the opportunities that exist, but need to understand how we can grasp them. We didn't hear, for example, in this opportunity about one of the ones I think is an extraordinary opportunity, and that's the dramatic investment in the community health centers across the country, an investment in access to care that is based in a community health center model that links prevention treatment, rehabilitation, and community engagement, particularly for the poorest and underserved across this country, and could very well be a model to the rest of the system. We also heard that this is not just the time for the public sector, but it's the time for the private sector. And Wells certainly brings to this a very practical reality of what we're seeing in terms of innovation coming from the private sector. Many on the Commission understand that what we're seeing is the growth of a new ecology of companies. When we think of the healthcare sector, most of the time we think of the pharmaceutical industry, the medical device folk, and the hospital sector. But now we're seeing that the innovative health promotion and prevention groups include the IT, software, technology, device, leisure, healthy food, and the list goes on and on. They represent the voice of that new unified ecology that could very well be a stronger counterweight to the forces that we've had till now to focus mainly on treatment and care. And then finally, I'd say the actual words and the bully pulpit do matter. We've seen that Surgeon Generals in the past have moved public opinion, have moved the legislative and regulatory process, have changed people's hearts and minds about what they do and the support they take. So when the Surgeon General talks about enough is enough in reference to tobacco, we know that he can be using that phrase with regard to many other aspects of public health that are unacceptable to tolerate today. And I would say one of the biggest ones which we should focus on was well illustrated by what Will put up, and that is that we tend to focus on improvements in public health measured by changes on the aggregate, on the average. What happens if we stop doing that and said this goal should be to close the gap between the counties who have the worst risks and the counties who have the best risk? And closing the gap could become the mantra for what is not only needed, but what is entirely possible because it has been achieved in parts of America. So if 20% of the country can achieve extremely low levels of smoking, have obesity rates that are 10, 20% below the worst, have hypertension rates that are reasonable, that must be achievable across the whole country. And I would love to see what the figures would look like if we actually simply allowed all the counties to achieve the health risk and status of the 20% best counties today. That doesn't require new knowledge or new technology or major new thoughts about what's working or what doesn't work. It simply requires a greater commitment to actually share the knowledge and share some of the investment ideas. Anyway, we're hoping that the Commission will allow the generation of some of this greater focus on prevention and passion, and I know that the Commissioners will bring greater clarity to how we can make sure this has a difference. And let me thank all of you here and those online and those busy tweeting for your input. We take them all very seriously, and we hope to continue the conversation. Thanks.